Hi, my name is Lita Rasulian, and on behalf of my classmates Lisa Elliott, Brent McElfresh, and Kenny Rodriguez, I'm here to talk to you about heel fat pad syndrome. Heel fat pad syndrome is defined as a painful, aching condition that affects the protective cushion underlying the calcaneus. It's part of a larger group of disorders that have been implicated in causing plantar heel pain. Much of the research out there addresses general plantar heel pain and not heel fat pad syndrome specifically. About 1 in 10 individuals will develop chronic plantar heel pain each year, so it is a fairly common and significant topic. Fat pad syndrome can result from a number of factors, such as an acute traumatic event, chronically from excessive heel strike with improper cushioning, or as a result of the aging process due to atrophy and thinning of the fat pad in the inferior heel. Now, the patient will usually present with complaints of a deep aching pain at the middle of the calcaneus that can be brought on or aggravated by prolonged weight-bearing activities or barefoot walking on hard surfaces. The patient can also present with night or resting pain. The symptoms are typically bilateral, and if the fat pad is atrophied enough, the patient may present with secondary neurological symptoms such as tingling, cold, and burning sensations. As of now, there are no known risk factors associated directly with the diagnosis of fat pad syndrome. This may be a result of the patient attempting to wait out the pain and then come to your clinic late in the disease process. A 2006 systematic review by Irving did reveal a possible association between fat pad syndrome and certain characteristics such as limited ankle dorsiflexion and increased BMI scores. But these findings are supported by little evidence and are mostly based on expert opinion and general observation. When attempting to diagnose a patient with fat pad syndrome, the ability to take an appropriate and accurate history is critical. Knowing the time of day in which the pain frequently occurs, the type of footwear worn by the patient, levels of activity at work and during personal time, and any past medical history related to the calcaneus and related structures will be very important. Some of these findings will give you the ability to differentiate between FPS and other diagnoses, which we will discuss later. The physical exam is also very important and should consist of range of motion of the foot and ankle, especially ankle dorsiflexion, as this is shown to be a possible factor for FPS. Palpation of the heel and general observation for edema and or atrophy of the fat pad itself should also be included in the primary exam. In this case, location of the pain can be a telltale sign of FPS or another diagnosis. Specifically, pain associated with FPS will be centrally located on the plantar surface of the calcaneus, whereas pain associated with plantar fasciitis will be found along the periphery of the calcaneus and the calcaneal tuberosity. Other methods for the diagnosis of FPS include imaging such as ultrasonography and magnetic resonance imaging, or MRI. Seen here are two MRI pictures. The picture on the left shows a normal fat pad with even borders and height in a non-pain generating scenario. The picture on the right shows a heel pad under compression of the calcaneus, and at the time of imaging there was a generation of painful symptoms for this patient. Ultrasonography is considered the gold standard of imaging in situations when the cause of plantar heel pain is unclear due to its relatively low cost and high output resolution. We talked about this a little earlier, but in order to correctly diagnose fat pad syndrome, it's important for a clinician to understand the difference between fat pad syndrome and plantar fasciitis, as these two diagnoses will present similarly to each other. FPS will include aching specifically in the middle of the calcaneus, provocation by prolonged periods of activity, a higher chance of bilateral involvement, and pain with standing. Plantar fasciitis will present with a larger pain area, symptoms with the first step of the day and continuing throughout, and more commonly will present unilaterally. It's imperative to make the correct diagnosis as treatment options will vary between the two. In fact, treatment by steroid injection, which is highly implicated in plantar fasciitis, has actually shown to increase symptoms of FPS due to the resulting atrophy of the fat pad post-injection. As far as PT interventions, one of the first goals should be to address lifestyle or activity modification through patient education, such as limiting high-impact activities and time spent on standing or ambulating at work or during leisure activities. Advice for appropriate footwear and possible orthotics, such as the use of heel cushions or heel cups, could be beneficial as well in short-term pain relief. Low-dye taping over the heel to add extra cushioning has also been shown to provide short-term pain relief. And finally, an individualized mobilization, strengthening, and stretching program has been shown to assist in addressing heel pain. It should be noted that there is a lack of literature pertaining specifically to physical therapy regimens that address Fat Pad Syndrome. As evidence for an individualized physical therapy program that addresses general heel pain, here we look at a 2009 RCT by Cleland et al. The objective of the study was to compare the effectiveness of two different conservative approaches for treatment of general plantar heel pain. The study consisted of 60 patients divided randomly into the manual therapy and exercise or MTEX group and the electrophysical agents and exercise group or EPAX group. The trial took place over a period of 4 weeks with a total of 6 treatments. Outcome measures were completed at baseline, 4 weeks, and 6 months. And you can see on the slide the outcome measures that were used for this study. Here we look at a few of the interventions performed by the MTEX group. The first picture shows soft tissue mobilization of plantar surfaces. The next is an eversion rear foot mobilization, and the third a rear foot distraction manipulation. These interventions also performed by the MTEX group are two methods of performing an AP talocrural mobilization, which is indicated with the talocrural joint dorsiflexion limitation. Now, each group also received a home exercise program in which the participants were basically told to continue activities which do not trigger symptoms and to cease those activities which increase symptoms. The patients were also given low and high intensity stretches for the gastroc and soleus muscles to address possible heel cord tightness. Here we have two more techniques given as part of the home exercise program. The first is an ankle eversion self-mobilization, and the second is a plantar fascia and FHL self-stretch. It's important to note that for the manual therapy and exercise group, the therapists utilize a regional interdependence approach, meaning they use manual therapy techniques to the low back, the hip, and the knee. The study results revealed that manual therapy and exercise are superior to electrophysical agents and exercise at both short-term and long-term follow-up in regards to function. Both groups revealed an improvement at 4 weeks for the reduction of pain, with manual therapy and exercise having a slightly better statistical significance. Cleland et al. Did mention that their study had some deficiencies. They recommended future studies to observe the differences in effectiveness of each manual therapy component, differences of effectiveness in the exercise components, a longer treatment period for the participants, and patient adherence to their home exercise program. So this was a systematic review done by Landorf et al., which looked at the possible types of treatment for general plantar heel pain. Based on what they found, they then categorized the treatments based on their effectiveness and safety. I'll discuss their findings within the next few slides. Custom-made insoles were found to be beneficial in the first 3 months of use in improving function. However, there was no consensus on whether or not they were better than prefabricated insoles. The heel taping method that you can see here was found to reduce pain within the first week of use, but there was no evidence on its effectiveness beyond 1 week. The additional interventions on this slide were found to have unknown effectiveness, meaning that there was either conflicting evidence or the evidence was not significant. Please take a few seconds to look over these treatment methods. Corticosteroid injections are commonly used to treat plantar heel pain, but we don't know whether they reduce pain compared with placebo or other treatments. As mentioned earlier, these injections have been associated with long-term complications, including atrophy of the fat pad itself. Oral analgesics and prevention of heel pain will be covered in future updates of this systematic review. In general, the prognosis for heel fat pad syndrome is dependent on the length of time with symptoms. So the longer the period of heel pain symptoms, the longer it will take to resolve. And as mentioned earlier with the Cleland study, receiving manual therapy and exercise has the best long-term prognosis to date. So what is the clinical bottom line for heel fat pad syndrome? It's very important to make the distinction that there really is not any evidence out there for the treatment of heel fat pad syndrome specifically, but there is a lot of evidence for the treatment of general plantar heel pain. Therefore, we should utilize the known treatment approaches for plantar heel pain for our patients who have heel fat pad syndrome. And manual therapy and exercise was found to be the superior approach for the treatment of plantar heel pain. Talking about the clinical bottom line is very fitting for this slide because there does need to be more research done to find a good treatment protocol for heel fat pad syndrome. Among other things, we also need to find out how heel fat pad syndrome can be prevented and what some risk factors may be. I hope you enjoyed this presentation, and here are our references.